Thanks for tuning in. This podcast and interview is brought to you by the Connecticut Women's Consortium. We post all of our new podcasts and free video resources on our website at womensconsortium.org and on our YouTube channel. So check out what we have and stay tuned for more. According to the American Academy of Pediatrics, the opioid abuse problem in the United States has grown into an epidemic, with an estimated 2.5 million Americans currently dependent on heroin or prescription pain medications. One of the many consequences of this growing public health crisis has been a marked increase in the number of infants born to mothers who used opioids during their pregnancy. The rate of Neonatal Abstinence Syndrome, or NAS, the syndrome of withdrawals these infants experience after birth, quintupled from 2000 to 2012. In a fascinating interview with Dr. Matthew Grossman, Assistant Professor of Pediatrics and Quality and Safety Officer at Yale-New Children's Hospital, conducted by Dr. Charles Atkins, a psychiatrist and Chief Medical Officer at the Community Mental Health Associates, we will review Grossman and his team's extraordinary initiative to improve the quality of care of infants with neonatal abstinence syndrome. Here is how Mary Lou Giovannucci of the Connecticut Judicial Branch, who has worked with Dr. Grossman to increase awareness of his work, describes what is being done to address this problem.
Dr. Grossman is a pediatrician who works at Yale-New Hospital, and the really groundbreaking work that he has done has changed outcomes for mothers and their babies who are born substance exposed. Dr. Grossman will be talking about substance exposed infants. He, in particular, has personal experience at Yale-New Children's Hospital with treating children, babies who are born substance exposed. He has done some very interesting research that has allowed us to learn more about what works when a baby is born in the hospital, and they have had some remarkable outcomes at Yale for babies stay in the hospital in neonatal and their discharge to home, which those of you who work for DCF, you know that can be a very challenging thing.
Please join us now as we explore this work in more detail with Dr. Grossman and Dr. Atkins.
Hello, and thank you for joining us for this podcast focusing on neonatal abstinence syndrome. I'm Charles Atkins, a psychiatrist and the Chief Medical Officer at Community Mental Health Affiliates in New Britain, Connecticut. Our guest today is Dr. Matthew Grossman, Assistant Professor of Pediatrics and Quality and Safety Officer at Yale-New Hospital, Children's Hospital. We're here today to talk about a recent study that was published this June 2017 in Pediatrics titled, An Initiative to Improve the Quality of Care of Infants with Neonatal Abstinence Syndrome. Welcome, Matt.
Thank you. It's great to be here.
So I guess let's start by orienting people to what exactly is neonatal abstinence syndrome?
Sure. So neonatal abstinence syndrome refers to a collection of signs and symptoms that occur in babies when they're born to mothers who have been using some sort of opioid. And these babies will often experience withdrawal symptoms that are not that different in a lot of ways from adult symptoms. It's sort of they experience a hyperstimulation kind of experience. They'll have a whole host of symptoms like tremors, high irritability. They will have difficulty feeding, difficulty sleeping, really having a difficult time coping with life, essentially. And this is caused by mothers using opioids. Often in our situation here, it's mostly prescribed opioids like methadone or Subutex, buprenorphine, but occasionally shorter acting ones like oxycodone or heroin.
How serious can it get?
So it can be pretty serious without intervention. So it is somewhat self-limited, and the babies will get through it, but often need some support. And they without any support, their difficulty feeding is potentially life-threatening, although again fairly easy to manage. The way it's been managed has been changing a bit over the last few decades.
Okay, could you maybe tell us a little bit about, prior to looking at your very innovative approach in the study, what has the traditional approach been to neonatal abstinence syndrome?
Well, this is neonatal abstinence syndrome is actually first described really in the 1800s when things like heroin were prescribed as cough medicine, and it was often fatal at that time, and it wasn't discussed very much in the medical literature until the 60s and 70s, and then really the 70s there was a heroin epidemic in Philadelphia, and out of that came a new approach to managing these babies centered around what's known as the Finnegan tool. And basically what this is a list of 21 different signs and symptoms of withdrawal, many of the ones I mentioned earlier. And they're all given a point value based on severity. And what would happen is when these babies were born, they would be scored usually every 4 hours or so with this scoring tool to see to categorize their withdrawal. And if the scores were above a certain cutoff, and for almost everybody that cutoff is a score of 8, then medication would be started. Much of the research over the last 10 to 20 years has been trying to figure out what the right medication is to treat these babies with, and the recommendation has generally been to use a like medication. So if you're withdrawing from an opioid, is to use an opioid. Although other medications have been tried either alone or in combination, and that's been the focus. What you'll find with most protocols and institutions and the American Academy of Pediatrics, they will list non-pharmacologic interventions, things like that are fairly basic in a lot of ways, like swaddling and holding and skin to skin and feeding the baby on demand as the first line treatment. But much of the focus until recently has really been on the medication part, which has been viewed more as the real treatment. If you would try the non-pharmacologic stuff, but then when you got, if they were actually withdrawing, you'd have to use medication.
Right. And so as you set about to do your study, that's where it sounds like things started at Yale, is pretty much all of these babies were being started on medication. Is that kind of where things started? Yeah,
particularly a really high percentage, and the published studies, the range of kids who are exposed in utero to opioids being started on medication was somewhere around 50 to 80%. We were quite a bit higher than that. And I looked at our methadone exposed kids for about a 6 or 7 year period, and we started 98% of those kids on morphine. And what we were doing when I started at Yale as a resident in 2003, when a baby was born to a mom who we knew was using opioids, the baby would be born and taken from the delivery room right to our neonatal intensive care unit, where they'd be monitored using the Finnegan tool and for signs of withdrawal. And once the scores got above 8, we would start them on morphine.
Wow, so it sounds like pretty much everyone was getting started on medication and going to your neonatal intensive care unit.
Yeah, I think when I looked, there was like 149 out of 151 babies were started on that were exposed to methadone were started on medication, and again we were using morphine at that time, and that was a little bit higher. But one of the things that we did a little bit differently, I think that other places was these kids went immediately to the NICU, and so one of the features of our NICU, the NICU is a pretty amazing place, and the things they do to save the lives of premature babies is pretty incredible, but it's not really the greatest environment for babies going through withdrawal. There's usually about 12 babies in a big room. It's loud. It's bustling. There's no place really for the parents to stay. So it's really hard to deliver a lot of the sort of regular baby care or that really supportive care. So it was kind of an environment that really you couldn't do that other than swaddling the babies. It was hard to do much else to support them other than medication.
Looking at where you started, and one of the things I find very fascinating about your study is the engine that was driving it appears to have been performance improvement activities. So could you maybe describe how you went from starting with pretty much all the babies, going to the neonatal intensive care unit and going on morphine, to how you got to this very, very interesting study?
Yeah, it was. I didn't really set out to do it. So I am not a neonatologist. I'm a hospitalist. So I do my clinical work on the general units. And what we would do with management of these babies is after they went to the NICU for usually a week or 10 days or so, they would be transferred up to the general inpatient unit. And I was the hospitalist on what we had at the time called the infant toddler unit. So this is where these babies came. And I was their pediatrician, from day 8 or 10 until discharge. And when I started, this was a pretty easy group of patients for me to manage because we had a protocol, which we followed. And there wasn't a lot of thought that had to go into it. Basically, these babies would come up on morphine, and then if they had 2 good days where their Finnegan scores were low, then we would go down on their dose by 10%. And so if you start to do the math, that means they were staying in the hospital a long time. And it turns out our average length of stay for these babies was 28 days, which was a slightly higher than average, but not that far off. And now the average length of stay for these babies nationwide is somewhere around 3 weeks, somewhere about 20 to 21 days, depending on which source you look at. So we were a little higher than that. Sorry, go ahead.
Yeah, no, and just to sort of jump a little ahead for our listeners, your study then got it down to?
We are down now to 5.9 days, which is, quite a bit below anything else that's been published out there. So we got there. It was a pretty drastic change, which is not, we weren't setting out to reduce it that far. And our goal, as you said, was sort of improving things like length of stay, but really we were looking for good outcomes for the babies and the family was our overall view.
Could you begin to lay out sort of the process you went through?
Yeah. So I could, yeah. So when I started taking care of these babies, we didn't set out to make any changes, and we just were following the protocol. And I started to notice a couple of things. First, it seemed like our protocol was taking a long time, and it didn't necessarily seem like we needed to wait 2 days for these kids to be doing well before we started to lower the medication. And so the first thing I did, without putting a lot of thought into it, was just kind of ignore that part of our protocol. So what happened then is, instead of going down every other day, we started to go down on the medication every day that the kid was doing well, which is pretty consistent with what most other places are doing. And just by doing that, we reduced our length of stay from 28 days to about 22 and a half days, which is putting us right at the time at the national average. And so it wasn't really putting a lot of thought into it. And what actually happened at that point that started to turn things around is one of our former residents was moonlighting at Middlesex Hospital. And I think their length of stay for these babies was more like 6 weeks. And somehow we found out that we had this reduction in length of stay. And they asked me if I could come and give a talk to them and explain what we had done to lower our length of stay. And so the problem with this is I had about 90 seconds worth of material for a presentation at that time, because I was pretty much just following our protocol and hadn't spent a lot of time studying these babies or the literature around it. So I had to spend a lot of time learning about it and reading the literature and really going over all the papers. And that's where I started to see something that seemed really interesting to me that I didn't have an explanation for. So there was a number of studies trying to compare different medications treating babies and trying to figure out what the right medication or cocktail of medications would work the best to reduce the length of stay for these babies in the hospital. And there were review articles lining them all up and figuring out which ones were the most statistically significant. Well, you took a step back and looked at the actual length of stay for the babies in these studies. Even with the babies would have similar exposures and by all accounts be fairly similar. And from study to study, despite using the same medications, the length of stays would range as widely as 10 days to 79 days. And with other medications, it would be 12 days to 35 days. So that is a really, really unusual finding in any other disease process that I can think of. That what you would consider to be the main treatment has this really incredibly broad length of stays, and it made it, I thought, really, really difficult to draw any conclusions from that. And it was hard to explain. And the explanation that I came up with was that maybe the medications weren't actually the most important thing. And so that's really where things started.
So tell a little bit more about, if it wasn't the medication, then what did you begin to suspect made the difference?
Right, and this is where I think we consider what we did probably not that terribly innovative, and I think we ended up really changing how we manage these kids. But basically, the first thing we did is we just took the American Academy of Pediatrics guidelines at their word. So the first line treatment was supposed to be non-pharmacologic care. We weren't doing that. And we decided, what if we treat non-pharmacologic care like it's a medication, give it sort of that same respect. So the way we wanted to think about it was, imagine a baby has pneumonia, you would give them antibiotics, and that's the first line treatment. So we just said, we're going to pretend that the non-pharmacologic care is like antibiotics for pneumonia. So when you start to think of it in that way, it really changes how you do things. And so the first thing we did is we really standardized how we were going to do this non-pharmacologic care on the floor, how we were going to have the families room in. We were going to control the environment to keep it low stimulation. We were going to feed the babies whenever they appeared to be hungry and started to get a little irritable. As soon as they started to cry, somebody was going to jump up and be ready to hold them, to swaddle them. And so we started doing that, and that was the first step, and that seemed to be going well. And then we thought, wow, so if these babies are going to our neonatal intensive care unit where we can't deliver any of this stuff, would you ever send a baby to a unit that had a baby with pneumonia to a unit that didn't carry antibiotics? No, that would be kind of crazy. So we said, well, we have to get these kids out of the NICU. We have to get them to a place where we can deliver this first line treatment. And so that was actually much more difficult than it sounds. And that part's one of my favorite parts of our story. So we had to negotiate first with our well baby nursery, who wasn't taking care of these kids, and they were really resistant initially. It took us about 18 months of negotiating to get the leadership and the staff and the well baby nursery to manage these kids until they started having withdrawal signs. And then they would be able to transfer them to our general unit, our general inpatient unit. And so it was really, they were really resistant. In fact, the first few kids when we started having in the well baby nursery, I think the first 6 kids came up with another medical problem that necessitated their transfer to the NICU within the first few hours, which I think was a kind of a protest vote. And so that's sort of where that started. And then over time, that the well nursery has become leaders in this, really, and they on their own really took on the same approach we were taking downstairs, and they end up doing about half of the management in these babies and do an amazing job, and have completely come around and are, again, as I said, are really leaders in our new model with this. So we worked on this. We did about 8 or 9 different steps. But after we started moving with this, after we said, okay, this non-pharmacologic care is the most important thing, we took another step back and looked at what we were doing, all of the aspects of our care. And what you find sometimes in medicine, and this was definitely a case of this, is the reason that you're doing things today is just because that's what you're doing yesterday. And there wasn't really much evidence or really reason for why we were doing almost every aspect of the care of these babies. And based on some of our observations, it seemed like maybe we were not doing things the best way for both the families and the babies.
Let me take it from that point. If you could compare and contrast the experience for the mothers and the families, both with how things used to be and how things really changed as a result of the study.
Yeah, I think this is a big part, and this is as I've gone to different places around the country, you see something that's pretty consistent, and that is that the relationship between the families, the mothers and the fathers of these babies, and the staff is not very good. It's usually there's usually some animosity there, and particularly you'll find that in the NICUs. And there's actually been a couple of qualitative studies, both on nursing staff taking care of these kids and on the moms. And I was really quite moved by some of the studies on what the mother's experience was. And after interviewing a bunch of moms, there were 4 major themes that came out in some of these studies. And one was that nobody really understood addiction. That nobody really understood what the parents were going through with battling addiction, which is not a big surprise. Usually, if you're interested in addiction medicine, being a neonatologist or working in a NICU, it would be a strange choice. So it's not usually something that we're dealing with as much in pediatrics. The second thing was that the moms felt really guilty because they knew that their baby was going through what they were going through, the withdrawal signs, because of what they had done. And so they were standing by and watching what looked like their baby suffering and knowing that they were responsible for that. So there was a lot of guilt. Another part is that they felt judged by the nursing staff. They felt like, the nurses also knew that the babies were going through this because of the parents and were kind of angry, and the moms felt judged. And when you go and look at some of the studies on nurses and their feelings during this, nurses say the same things, that yeah, they're kind of angry at the moms and they're judging them. So it was sort of that feeling was not coming from nowhere. And then the moms felt like they didn't really trust the staff because of this animosity. And so we thought that was a pretty lousy way to get started as a parent. And so our goal was to try to not have the moms feel those things. We may not understand addiction well as pediatricians, and we maybe haven't improved that, but we do understand parents and we understand babies, and we wanted to try to be as supportive as we could. And so what we really tried to move towards that was going to help this was a model. The normal model is where the staff takes care of these babies for 3 or 4 weeks, and at the end of it kind of hands the baby off to the family, who has visited the baby, has not necessarily bonded, has not been doing the care for the baby. And often when we're sending these babies home, they're still having some withdrawal signs, and we're handing off to often a family that doesn't feel ready to take them home. And what we found initially is we'd have these babies here for a month, and it would be time to discharge, and the parents would be asking for another day or two at the hospital, which seemed always a little strange to us. And so what we want to do is to turn this, and instead of having the staff taking care of the baby, is that we would have the parents taking care of the baby and doing all the care. And so it may have been that the moms, what the moms were taking was responsible for the symptoms for the baby, but now we were telling the moms that they were the treatment for it. They're the ones who were going to make their baby better. It wasn't going to be us, it was going to be them. And so our focus was to empower the parents, the moms in particular, to be there and to be the treatment for their babies. And then our role wasn't to care for the baby, but was more to be coaches and cheerleaders for the parents to do the job. And instead of spending a month taking care of the baby and then handing it off to the mom, now we're spending about 4 or 5 days training the parents and coaching and troubleshooting with them on how to care for their baby. And then by the 5th day, the parents are standing at the door saying, "Hey, can we go? We got this. We're doing the work and we got it." And it's a really, it's just a much different experience.
And so just to summarize a little bit, because there's some very stark differences. So a neonatal intensive care unit, there's no rooming in. But it sounds like in both the well baby unit and up on the floor, that's really the model, is that the mom, the parent, is actually rooming in with the baby.
That's right. That's the treatment. And actually, we really evolved the way we thought about that. I think in the beginning, we allowed the parents to room in on the floors and in the well nursery. And then we said, wow, this is really important. We need to encourage them to do it. Then we went back to our original model. We said, okay, well, the parents are like the antibiotics for pneumonia. When you order antibiotics, you don't encourage the pharmacist to send the antibiotics up. You need the antibiotics. That's the treatment. So as we became more and more convinced that the parents were the treatment, we were a little more aggressive and messaging that to the families. We did it in a very supportive and positive way, but we didn't encourage them. We said, you are what your baby needs, and you need to be here, or somebody needs to be here. How can we troubleshoot? How can we help to make that happen? Because that's the treatment.
And as we look at some of your outcomes, there's one that I'm really fascinated by, actually several. But could you comment on what happened with breastfeeding in this study?
Yeah, this wasn't a specific goal in the beginning, but our breastfeeding rates in the beginning of our study were fairly close to zero. They were under 10%. And there was always issues with whether we would be encouraging the mothers to breastfeed or not. And I think the recommendations in the beginning were based on the dose of methadone that the mom was taking. If it was over a certain amount, then we would discourage breastfeeding. And then if it was under, we would be okay. But there was always some delay with whether we thought it was okay for them to breastfeed, and it really wasn't something that we encouraged. And plus, if the baby's in the NICU and you're only visiting sometime, it's a little bit hard to get that bonding and getting that going. But we became a baby-friendly hospital, which means that the babies and the moms are together. That we don't really have a nursery. The babies are in the rooms with the moms. We have lactation consultants. We lifted many of the restrictions on mothers who were in programs and adherent to their programs. We were not just allowing, but encouraging breastfeeding. And that bonding and that closeness was also helping with the withdrawal. And so babies who are breastfed actually do much better. And so our breastfeeding rates got above 50% and have hung out above 50%. We still think we have some room to improve that, but it's obviously much better than almost nothing.
Do you have any deal breakers for breastfeeding?
So there are some guidelines around breastfeeding, and again, some of this is it's not really our decision with breastfeeding, and that's why we say we encourage or discourage breastfeeding. And so generally, if there are illicit drugs being used within the last 30 days, then generally it's discouraged until the mother can show that she's off of those drugs. A little bit of whatever you're taking tends to get into the breast milk, so there can be some danger in that. And the safety of some other drugs, like now the question of how safe marijuana is, has really made that a kind of broader issue than just in caring for these babies. So generally, though, if you are in a program and you're not taking anything else, then we encourage it. But we're still working on, and so it's really the rest of the country, guidelines of how to manage other medications besides methadone or Subutex or things like that.
Now, you mentioned early on, that the standard was using this Finnegan withdrawal assessment tool. and that you've now switched over to what sounds like a much more pragmatic approach. Could you just maybe delineate what it is you're actually looking at that may make you decide, we have to use a little medication or not?
Yeah, this is one of the, there's really two things we did that were major changes, and this is one of them. And again, this was based on us just asking, why are we doing it this way? And when we asked that about the Finnegan tool, we didn't have an answer. And when you start to look more closely at the Finnegan tool, it does a really good job of cataloging the signs of withdrawal. So it's a pretty exhaustive list of all the withdrawal signs a baby can have. So that can be helpful if you're trying to figure out if a baby's withdrawing. But what I have found, and I've seen over 500 babies exposed to methadone, and I think there might have been one that I couldn't find withdrawal signs on. So that's 499 that had withdrawal signs and maybe one that didn't. So if I concede that these babies are going to withdraw, I'm not sure how helpful the Finnegan tool is. When you get into some of the more detail of the Finnegan tool, it starts to seem a little bit absurd, considering what the stakes are, and it's whether you're going to give, if the scores are high enough, it means you're going to give medications like morphine or phenobarbital, which we either don't know the safety profile for that in babies, or we have a sense that it might not be that safe. So, for instance, one of the categories in the Finnegan tool is sneezing. And so if you sneeze 3 times, that's okay. But if you sneeze a 4th time, you get a point. And that point might mean that you get morphine. Yawning is another one, same idea. 3 yawns is okay, but that 4th yawn means that you would give morphine, which is, again, somewhat absurd, and we would never do that for anything else. So we said, okay, if I can see that these babies are withdrawing, I don't really care if they're yawning or sneezing a little more or less. What do I care about? Well, I want to know, if they're having withdrawal signs, are they still able to function as a baby? And you know, the job description of a baby is pretty limited. So they're not supposed to do all that much. They're supposed to eat, they're supposed to sleep, they're supposed to poop, which usually isn't a problem with these babies, so we didn't really think about that one. And you should be able to calm them down in a reasonable amount of time. And so even if you're having withdrawal signs and you can eat, you can sleep, and we can calm you down, then in our minds, that's well-managed withdrawal. And we are doing well, and you are getting to be a baby. And that's really what our long-term goal is. We want the babies to do okay, and we want them to do okay here and then long-term. So that's what we looked at. It's really the same things we look at with every other baby. And that's one of the things we kind of joke about, is that in managing these NAS babies, the first thing to do is just pretend they're babies and see how that goes. And so that's really what this stemmed from. So instead of having these 21 different items, we're just looking at whether they're eating, sleeping, and whether we can calm them down.
Okay, so just a very pragmatic approach that if the baby's being a baby, you're not medicating.
Right. Yeah. Seems most of the stuff in my mind just feels like common sense, but we kind of got pushed down this standard pathway, and just being able to step back and look at everything. Most of this stuff is really, I think, pretty intuitive and kind of common sense. And what I found is, when I talk about this with people who have no experience with these babies, they think a little of what we're talking about seems ridiculous. So why weren't we doing it this way all along? Is the question I get from people who don't have experience. If you've been taking care of these babies, this seems pretty radical, but for anyone else, it seems like common sense, which I kind of agree with.
Now, in the midst of probably the biggest opioid epidemic in certainly modern times, could you summarize, because you mentioned really this radical decrease in the average length of stay, but could you review the results overall that you found?
Yeah, so what we found, we looked at a few different things. The major outcome for us was trying to reduce our length of stay, and originally our goal was to try to get down to somewhere around 2 weeks. We thought that was pretty ambitious, and so when we started the project, really we were at an average length of stay of 22.5 days, which was right around the national average. And then through about 8 or 9 different interventions, including several of the ones we mentioned, we reduced our length of stay, not all at once, but over time. And really over the last now 2.5 years, our average length of stay has been 5.9 days. We were treating 98% of our methadone-exposed babies, and methadone-exposed babies tend to have the most severe withdrawal. We were treating 98% of those babies with morphine. And now the way that we say it is, so now initially we were treating 98%, and now we are treating 100% of them aggressively from the time they're born with non-pharmacologic care. So and this is a new way of talking about it, that most places, when they think about treating these babies, they're only speaking about medication. But we are finding that the non-pharmacologic interventions are so powerful, and that is treatment we were doing on every one of these babies. But we're only giving about 10% of them any morphine. And so that's quite a big drop. And as you mentioned before, our breastfeeding rates went from somewhere around 5% to about 50%.
Oh, no, I was just going to say, and then as you look at, these incredible drops in length of stay and going from a NICU, which is incredibly expensive per day, to less expensive and certainly shorter lengths of stay, I imagine the financial ramifications are significant.
Yeah, the hospital's been pretty happy about that part of it. So these are also about 95% Medicaid payments, which is not the best for the hospital. So yeah, we've cut per year just in our hospital costs, not in charges, but in actual costs, somewhere between $1.5 and $2 million a year, just in cutting the length of stay on these babies.
So the implications for that, obviously, on a national basis, if your study were to be replicated, and can you talk about how is this getting disseminated at this point?
So I've been on a bit of a speaking tour about it, and getting some of the data published has helped. But there are a lot of people who are, I think, waiting for something like this, and we're frustrated with the Finnegan tool and how we were managing these babies. So there's a few places across the country that have already adopted much of what we've done. Most notably is Boston Medical Center has really taken on almost all of what we've done. One of the major hospital in Santa Fe, New Mexico, I was just there. They've adopted everything and seen dramatic reductions in length of stay. My favorite one is Middlesex Hospital, which is the hospital in Middletown that was the first one that invited me to speak where this all started. They came to visit us maybe 9 months ago, and on their drive home, they completely changed their model of care. And since then, their length of stay has been about 6 or 7 days. So I'm kind of most proud of that one. And there are a number of places, a number of state collaboratives that are interested in adopting this. New Hampshire and Vermont have the birthing hospitals have a collaborative they're now moving to using that eating, sleeping, and consoling model of assessment. Massachusetts is planning to follow suit in September to start that process. I'm also meeting with NAS collaboratives in Maryland and Indiana as well, coming up in the next couple of months, who are looking to adopt this kind of thing. So I think our hope is that this becomes the standard of care. We really feel like this is kind of a win-win. It's better for the babies, it's better for the families, and better for the hospitals as well.
Now, while it's not a part of this study, I wonder if you can comment on, has there been any look at how these babies are doing after they leave the hospital?
So that's a great question. That's one of the things we're really missing in this is really good follow-up data. So we really don't know how NAS babies do when they're 6 months old, 5 years old, 10 years old, as adults. There are a few small studies, but it's really difficult to draw any conclusions at this point. And we certainly don't know if there's any difference between using the traditional approach versus what we're doing here. What we are doing now is we're trying to follow these kids more closely. And we've started doing more behavioral testing. We have a clinic set up that we have been using for the last year and a half to try to do developmental and behavioral testing over the first 3 years of life. And we're going to start to look at our population and how they're doing in both the short and long term. But that's going to take some time. So, with our new model, we've only been really had it implemented for the last 3 years or so. So it's going to take some time to get those answers. But that's a really, really important area of research coming up.
And one thing that you do comment on in this article is that there were no readmissions within, I think, 30 days.
That's right. Yeah. So that's as one of my colleagues says, you can really discharge everybody early, but they just may come back. But what we found is what we're doing is they're not coming back. It doesn't mean they're not still having some withdrawal signs at home, but the parents have been managing them in the hospital and know how to do it. So there's no need to come back. We've occasionally heard there's occasional babies who still have withdrawal signs for weeks, and we've gotten a couple of calls just to say, hey, is that normal? We've got this. Everything's fine. We can handle it. We just want to make sure everything's okay, which is kind of a much different call than we used to get, which would have been just bringing the baby back. So yeah, we've had no readmissions during the study period, which is a really good sign that we're preparing the families well. And again, that's kind of what we look like as our role in the hospital.
And any other areas within the study that you'd like to comment on, or that have struck you as things that you found, or areas that you want to pursue further here?
Yeah, there was one other area that's kind of a big change that we're just getting a couple other hospitals to follow with this is when and again, this goes with you just kind of do what you were doing the day before. If infants with NAS don't need medication, they're usually discharged about 4, 5, or 6 days of life. Now, if they do tip over using the Finnegan tool where they need medication, then they buy another usually 2 weeks at least of hospitalization, and that's usually at least 100 doses of morphine that they're going to get. And there's really no middle ground. And so and why is that? And when we asked why, we found no answer. That's just how everyone's always done it. And we said, well, why? Well, I'm not sure that's necessary. And what we found instead is, with the focus on non-pharmacologic care, what we would do if we had a baby who we couldn't console, let's say it's 3 o'clock in the afternoon, and we would have difficulty consoling them. We tried everything. Our first approach, instead of going to medications, if we went in there and the mom wasn't there, is to find out if we get the mom to come back. But if we had a situation where we had done everything we could to increase all of the non-pharmacologic care, make sure the environment is calm, swaddle and feed them, and they were still inconsolable, we would give a dose of morphine. As that settled things down, when the next dose was due at 6 o'clock, instead of doing 100 more doses over the course of the hospitalization, we would see how they were at 6 o'clock. And if the mom was back and the kid was calm, we wouldn't give any more medication. So instead of using these weeks of medication weans, we would just use the morphine as needed. And again, we use it very infrequently, but when we've used it, the last 3 kids, I think, had a combined total of 7 doses, as opposed to what would have been a combined total of several hundred doses. So I think that's a big change. And it also, what happens when families are experiencing the Finnegan scoring, they know that if they get over those magic numbers of 8, that they're going to be stuck in the hospital for a few more weeks, and their baby's going to be on medication. So there ends up being animosity around the scoring, and they're arguing for lower scores, which seems to be the wrong thing to focus on. And I think with our approach, they're just focusing on how the baby's doing, and we're kind of all in it together.
So instead of the Finnegan score, it's the eat, poop, and swaddle score.
Eat, sleep, and console is what we've called it. The escape, ESC.
ESC.
We didn't have a branding person, so that's the best we could come up with.
And you mentioned in the article that the Finnegan scale itself, in order to do it, you're having to unswaddle the baby, which might actually elevate the score, just by sort of arousing the baby and making them uncomfortable.
Yeah, I think it's some of the items are, you have to figure out if they have tremors when they're disturbed. You have to see if they have a exaggerated Moro reflex. These are all things you have to unwrap them and kind of see if you can get them to withdraw, which is really goes against the whole idea of the treatment. So in my mind, the Finnegan score, if you do it appropriately, actually can do some harm, which is not a great thing. So I think there's quite a few problems with it. I think, again, it's good at identifying withdrawal, but in terms of management, I think it's got a lot of problems and shouldn't be used for that.
As we hit the last few minutes here, I don't know, could you comment on some of what the relationship has been like with your study? And it sounds like where this has all been with mothers who are on methadone. What's the coordination been like with the area methadone clinics and issues that might have arisen and that kind of stuff?
So that's a great question. I think we probably haven't done a good enough job coordinating with the methadone clinics. So one thing that we've been focused on making sure that the mom and baby can be together, so the mom can stay in the hospital. And most of the clinics, some of them are residential clinics, and a lot of them have been helpful with that and allowing the mothers to stay as much as possible. And the other area is the mother's dose of methadone while they're pregnant goes up usually quite a bit. There's a lot more. They have a lot more water, and they need a higher dose to keep the same level. But once they deliver the baby, their dose is often too high. So we've worked with the methadone clinics to get those doses down a little bit sooner, so that the moms aren't quite so sleepy. So they can they have an easier chance to respond to their babies more quickly. But generally, it's been one of the things that's helpful for us is the methadone clinics are very close to the hospital, so the moms aren't driving for an hour to get their methadone and then coming back. They're going and they can come right back in a few minutes, which has been really helpful.
Has there been a process pre-delivery where moms are sort of prepped that they may be going into a study or a protocol, anything like that?
Yeah, so it's not, they're not told they're going into a study. They're explained. We have a care coordinator who works with the pregnant moms who are using opioids, and explains what it's going to be like in the hospital and what the expectations are, how the treatment's going to go, how they're the key to treatment. We have a handout for them, and we may work on trying to do consults with the moms, having the pediatricians. We haven't done that yet, but having us meet with them before delivery. But right now, most of these moms are coming in when they're coming from our clinic, and they know what to expect. They know they're in charge. And that's been really helpful. And they come in empowered. They know they're going to be respected, and that we're gonna do our best to care for both them and their baby. So that's working out very well. And it's a really important part of it. So it's not a surprise. It lets the moms make some arrangements if they have other kids at home, so that they can be here.
Okay. Anything else that we've not covered here?
I think that's most of it. I think that's it's been exciting to see the improvement and how it's affected the moms and the babies, and it really feels like it's really improving their experience and really setting them up for success at home. So we're really excited about that part of it.
And maybe just to clear the board on the neonatal abstinence syndrome topic, while you're focusing on methadone, you'd mentioned earlier that with other opioids such as buprenorphine, oxycodone, or heroin, in general, the experience is that neonatal abstinence syndrome is generally less of an issue?
I wouldn't say that. I say it's really an issue for all of those medications. What we have found is it's the length of stay, everything's slightly worse with the methadone exposed kids. But if you have prolonged exposure to any opioid prenatally, you're very, very likely to have withdrawal signs. So we do, it's the same protocol no matter that we do, the same approach, regardless of the exposure. Most of our kids, about 80%, are methadone.
Okay, well, I think we've pretty much covered the topic. Let me just look back through my list of questions here. Okay, Dr. Grossman, thank you so much for joining us. And to listeners, I hope you will participate in other courses being offered online by the Connecticut Women's Consortium. Thank you.
It was my pleasure. Thank you.
Thank you for listening to this podcast brought to you by the Connecticut Women's Consortium. To learn more about this particular topic and earn continuing education credits from home, consider taking our online course, Women, Babies, and the Opioid Epidemic, where you will learn more from Dr. Grossman and Dr. Atkins, as well as Jordana Frost, who discusses maternity care experiences and outcomes, as well as the effectiveness of perinatal health services. You can find this course, among many others, on our website at womensconsortium.org.